Hi, this is Herb Kressel, and welcome to the December Radiology Podcast. This month we have three fascinating discussions. First, I'll be speaking with Dr. Chris Whitlow, who is the Chief of Neuroradiology at Wake Forest. And Dr. Whitlow and his colleagues authored a paper relating subconcussive head impact exposure to white matter track changes over a season of youth football. That discussion will be joined by Mr. Chris Nowinski, the CEO of the Concussion Legacy Foundation. I'm sure our readers and the general public will find this discussion on this most important topic of great interest. Next, I'll be speaking with Dr. Pari Pantharapande, who with colleagues at Massachusetts General Hospital authored a provocative study on the changes in physician decision-making after computed tomography, a prospective multi-center study in primary care settings. And finally, Dr. Deborah Levine, our Senior Deputy Editor, will be speaking with Dr. Emily Conant of the University of Pennsylvania, who with her colleagues authored an important study looking at the implementation of synthesized 2D mammography in a population-based digital tomosynthesis screening program. We think that these discussions will be of great interest and look forward to your comments. Hi, this is Herb Kressel, editor of Radiology, and welcome to the December Radiology Podcast. We have a very special conversation today, and joining us is Dr. Chris Whitlow, who is Associate Professor of Radiology and Chief of Neuroradiology at Wake Forest University Medical School. And Dr. Whitlow, with his colleagues, published a very intriguing study relating subcompressive head impact exposure to white matter track changes over a single season of youth football. And this work has attracted a lot of attention. Welcome, Dr. Whitlow.
Thank you. Thanks for having me.
Sure. We're also delighted to be joined by Mr. Chris Nowinski, who's the CEO of the Concussion Legacy Foundation. And welcome, Mr. Nowinski.
Thanks for having me, Dr. Kressel.
Yes, Mr. Nowinski, can you tell us a little bit about the Concussion Legacy Foundation and what you all do and what you've accomplished?
Sure. I started the Concussion Legacy Foundation in 2007 with Dr. Robert Cantu, who was my treating physician when I had to retire from WWE due to a concussion in 2003. My eyes were open to the fact that we didn't handle concussions properly and that there were long-term consequences we weren't talking about. And so the foundation exists to help change the culture of sports, advance science, and protect athletes.
I see. And the foundation has organized the pathologic examination of former NFL players looking for chronic traumatic encephalopathy. Is that correct?
Correct. We partnered with Boston University and the VA in 2008, and we now have the world's largest brain bank focused on understanding the long-term effects of brain trauma, specifically CTE. We now have over 200 cases of CTE diagnosed in the last 8 years, and that's now 70% of the world's total. So we're really finding that we've given a lot of athletes CTE over the years, and we're excited about research that might help us change that pattern.
Well, thanks so much for joining us. I know that you were interested in this study when it was published. And Dr. Whitlow, can you give us the background here? As I sort of read it, I was just curious, how did you actually get the idea and how did you organize it and how did you get all the moving parts together?
Sure. Well, like all really good ideas, it really came from kind of a bunch of people being in the right place at the right time. So there was one phone conversation, kind of a conference call in particular, where I was on this call. Our collaborator, Alex Powers, who's a pediatric neurosurgeon here, was on the call. My mentor and former chief, Joe Malgin, who's now at UT Southwestern, was on this call. And then also my biomedical engineering collaborator, mentor, colleague, Joel Stitzel, was on the call. And part of the conversation was about football. Virginia Tech and some of our collaborators there, Stefan Duma and his team, have a long history of instrumenting collegiate football players. And we were talking about the fact that there's a lot of funding and a lot of interest in studying concussion and head impact exposure at the collegiate level and at the NFL level, but not much had been done in the youth and high school leagues. And the reason why this was so odd to us is because if you think about it, there's maybe around 2,000 active NFL players. There's maybe 100,000 collegiate players, but there's more than 5 million youth and high school players. Wow. And there's this disease entity, chronic traumatic encephalopathy, that people are talking about with NFL players, et cetera. And one idea is that this isn't something that just happened due to NFL football exposure, but maybe something that is the consequence of a long-standing, lifelong exposure to head impacts. Because after all, most of the NFL players were also youth players, high school players, collegiate players before they reached the NFL. The other issue is that there's a lot of information now about concussion, and I think there's a lot of converging thought that concussions are bad for the brain. But what about all those other head impacts that don't necessarily lead to a concussion? But should we be worried about those? And is this just part of a lifelong exposure that we need to address at the very beginning of someone's career rather than looking at it at the end of their career?
Mr. Nowinski, are you aware of work like this that's going on elsewhere, looking at youth football players and looking at diffusion or these some measures of subconcussive change?
Well, what's really special about this study is they've reached a population that no one studied before with this technology. So, as was mentioned, the college football players have been studied. High school football players have been studied. A lot of that work outside of Virginia Tech and Wake Forest has been at Purdue University, where they have seen changes in the absence of concussion, whether it's diffusion tensor imaging or functional MRI or functional changes. What's exciting about this is, as was mentioned, the children are the most vulnerable based on a whole lot of ways we can discuss it. And this is the most difficult research to conduct because you don't have that medical infrastructure to rely on to get the work done. So it's possibly the most important, it's definitely the most important answers to get is, what are these hundreds of hits to the head doing to these young men while their brains are developing? Right. And so the fact that there are positive findings from this study should really, the foundation will use this information to help reform youth football, to make it safer for these kids. It seems pretty clear that the more we hit them in the head, the more we're finding that something's happening in the brain that we have not seen before.
Right. So getting back to your work, Dr. Whitlow, can you expand a little bit about what's kind of the basis of what's different in a young person's brain than in an older person's brain, not counting the atherosclerosis and all the other aging changes, but about brain maturation in particular that might make these people susceptible?
Yeah, I think that's a good point. The issue is that children's brains are constantly changing, and the brain in general is constantly changing. And just as you learn in medical school about the stages of development for babies and toddlers, children and youth and high schoolers and adolescents go through all of these different stages of development with different functional output that's coming online, with things like executive functioning, maturing later in adolescence. And so the thought is that even if you understand what's going on in the brains of a adolescent, that doesn't necessarily tell you what's going on in the brains of a youth player. So you could have same amount of exposure, same location of injury, two different outcomes based upon differences in the developmental trajectory of youth versus adolescence. And this is also true of boys versus girls, and that's something we can talk about later, is extending these sorts of studies from just boys into girls. You just can't understand what's going on in, let's say, a college player and think that you can extrapolate that to youth, high schoolers, boys and girls. It's all different.
Now, in the paper, you said something else that I found particularly interesting about the time course of myelination. That the myelin is continued to be laid down, and it increases as you move to adolescence. And so, it occurred to me that one of the functions of myelin, in addition to sort of making the traffic go smoother, it could be an insulator for the axons, and it might be more vulnerable if there's less myelin being laid down at that time.
Yeah, I mean, I think that's a good point, and the answer to that is we're still not really sure. So, there's a lot we don't know about how myelin is laid down. There's a lot we still don't know about all of the functions that it can have, and still don't know if you alter that laying down of myelin in any way, what the functional outcomes of that might be in the future. There's a lot we don't know.
So I think a lot of people are interested in the system that you use, the HID system, and particularly the output that it does, something that you call a risk-weighted cumulative exposure, and then you even put the icing on the cake with the combined probability risk-weighted cumulative exposure. Can you tell us a little bit about what this means and how it works?
Yeah, I can tell you a little bit about it. I mean, this is the benefit of this kind of study, is that it's very multidisciplinary. So this is the domain of my biomedical engineering colleagues, Joel Stitzel, Jill Urban, who are co-authors on the paper. But first of all, the HIT system, head impact telemetry system, are a bunch of spring-mounted accelerometers that are embedded in the little gaps of the football pad. They're specifically made, in particular, to work with Rydell helmets, and can be fit into those very nicely. And then the football helmet is placed on the participant's head, and the spring-mounted accelerometers are in contact with the head, so that when their head is hit, it can determine a lot of information. It can count hits. It can determine the linear acceleration that's exposed to the head. It can detect the rotational acceleration that's exposed to the head. And then you have to then there's ways of taking that data and kind of modifying it by the risk of concussion from data that's been gathered using similar systems. And so what we really looked at was the weighted sum of the risk of concussion caused by all these linear and rotational accelerations for each impact. And so there's a lot of interest in the difference between linear accelerations to the head and rotational accelerations to the head. What we found is that, and again, my biomedical engineering colleagues could speak to this better, but certainly rotational accelerations are very important and contribute to changes that people are seeing out there in the literature. But what we found but also linear accelerations are also contributing. But the combined is I guess contributing even more than either one separately. So that's why we're looking at the combined data. So the combined linear and rotational exposure that each child had. And the great thing about it is that you can boil that down to a single number for each player. So each player ends up with a single number that's representative of their combined linear and rotational head impact exposure for all games and all practices for a single season of football.
And can you separate those if you wanted and look specifically at the relationship with linear or rotational?
Yes, you can totally do that. You can look at linear and rotational separately, and then you can look at the combined linear and rotational.
So tell us exactly what you did in the study, what it consists of, and then highlight your key findings, if you would.
Sure. So we took a team of youth football players who were around 8 to 13 approximately. And
one team basically rather than a league, it's one team?
Well, we actually have a few teams instrumented now, but it started out with one team.
Okay.
And so then each player has a football helmet which is instrumented with these detectors in it. They wear this for all practices and all games. Each practice and game is video recorded so that our poor graduate students can go back and watch it and match up each head impact with an actual head impact, one that's detected with the sensor to match it up with one that's video recorded so that you can exclude things like dropped helmets, etc. Then what we did was we imaged all the players at the beginning of the season with MRI, multimodal MRI, including structural sequences, functional sequences, and also magnetoencephalography, or MEG. We did that at the beginning of the season, at the end of the season. And then also if someone has a concussion in the middle of the season, we will capture another set of imaging data. We also acquired functional cognitive data at the beginning of the season and at the end of the season, and also if someone had a concussion. We haven't really finished analyzing those data, but we're starting to kind of dig into that. And then basically we have at the end of the season a way to compare within a subject how much their brain has changed between the beginning of the season and the end of the season. And we already know that the brain undergoes a lot of changes. This was only about a 3-month interval between the beginning of the season and the end of the season. And what we saw are changes, which again, not so surprising, but the thing that struck our attention or caught our attention was that the changes that we were seeing had a linear relationship with the amount of exposure. So the more exposure, the more change, the less exposure, the less change between the baseline and the follow-up.
And the changes you reported in this article were primarily in the direction of the neurons, the fractional anisotropy. So normally the diffusion is very linear along the neurons, and you showed some alteration in this, and the degree of alteration was associated with the degree of trauma as recorded on the sensors.
That's right.
Now, you've found the changes particularly in 2 locations, the inferior frontal fasciculus and the superior longitudinal fascicula. So what do we know about these that might make them particularly susceptible to trauma?
Well, the specific tracks that we chose were based on literature that we found. They're evidence-based that in these tracks, they are known to be undergoing a lot of change within this age group. So kind of our overarching hypothesis was that, perhaps the areas of white matter that might be most vulnerable to exposure would be the ones that are undergoing the most developmental change. And these are also tracks that have been reported in the concussion literature, the TBI literature, that people have identified changes in these. So they seemed like good candidates to start with.
Okay. And the other thing you identified that I found intriguing was that you looked at the location of change in diffusion, and it tended to be, at least by your estimates, near the junctions of the white and gray matter on these tracks. Any thoughts as to why these might be particularly susceptible?
Yeah, as I was thinking about it, the reason I started to think about that was because as a neuroradiologist, often when you see at least there's a certain kind of injury called diffuse axonal injury. And
that's what I thought about it.
We're not in the realm of injury necessarily here, right. but there's this idea that something happens and that there's some maybe material property that might make the junction of where white matter and gray matter meet, that might make that a little bit more vulnerable. And again, it could be differences in tissue characteristics and the mechanics of how those two tissues come together and the propagation of a force wave that goes through that. Perhaps it affects it at that junction. But the idea was to maybe look a little bit more carefully at these tracks. A lot of people have found changes in tracks, but because of the kind of mechanical questions we were asking, we thought wouldn't be interesting to look at the whole track like everybody does, but then also kind of break that out into the core of the track, and the ends of the track. I mean, we can't necessarily say that we're at exactly the gray-white junction. That'd be very difficult to define. But we're looking at that area that might be comprised of that junction separately from the whole track.
So I know you're certainly have had a lot of attention given to this study. It was covered widely, and I've sort of the question that as I sort of look at social media, everyone's saying, what is the take-home messages? What should readers who are physicians and parents who may just be seeing this podcast, what should they be taking away from this work? And Mr. Nowinski, I'll ask you the same question once we hear from Dr. Whitlow. So,
Sure. I would guess raise an element of caution. I mean, this is, after all, a study of 25 subjects. So I think you have to be real careful about making big decisions based on a study of 25. I think for us, the takeaway message was that we're asking the right question. No one's really asked the question about, does exposure affect the brain in any way? And I think we're at least seeing some preliminary evidence that maybe it does. I think the question in our mind that remains is, well, what does that mean? Football is a really physical sport. So does it surprise you that there are changes to a player's body after a season of play? Well, a lot of changes, physical changes from football go away. Little nicks and bruises and cuts. Perhaps these changes that we're seeing in the brain might be in that category. The reality is we don't know, but we know we're asking the right question. And I think you have to put it in the context of all the health benefits of sports-related activity. I mean, we're sort of in the middle of an obesity crisis with our young people, and what we need them to do is get out and be more physically active and participate in sports. And there are enormous, it's very, very well known, very well documented that there are enormous benefits to sports-related activity, particularly team sports, where you get a lot of leadership experience, you learn to play with a team, you learn camaraderie. There's so many good things that come from sports. I think it's too early to, for example, say that people shouldn't play these sports, but I think it's important to say that we need to study this exposure a little bit more, find out if the kinds of changes that we're seeing, persist, go away, accumulate over multiple seasons, and apply it to a much bigger population before we can sort of generalize it to all players. And I think it's important to also keep in mind that there are girls playing sports and that you can't generalize these kind of findings to girls. Your other part of that is, what's the take-home message for parents? Well, there's a lot of things that, I think the reason why parents are really interested in this study is because we all want to get the most benefits out of this sports-related activity and decrease the risks to our children as much as possible. We want to keep them safe. And there's a lot of things that you can do right now to keep your kids safe, particularly in contact sports like football. Some of those things are knowing the signs and symptoms of concussion. I think it's important for coaches to know this. I think it's important for players to know this. I think it's important for parents to know this. If something's happening on the field, if a player doesn't feel quite right, if a coach is watching a player and he's worried about them, if a parent is watching a player, they're worried, they just need to get the player out and get them evaluated by a professional. I think one thing that we've really appreciated from this study is the ability to get athletic trainers and get them involved. In North Carolina, athletic trainers are required to be at high school games, but not necessarily youth games. Mm-hmm. And we've had athletic trainers on the field for all practices and games, and these are professionals. They are trained to identify signs and symptoms of concussion, and not just concussion, but all injuries. And having them on the field is important. It's an important component of maximizing the safety of children. It's also important for parents to know what's going on the field. One thing that is apparent to us is that 60 to 70% of youth football is not really regulated. There are some regulated leagues like Pop Warner, USA Football, but the vast majority is not regulated. There's simple things that we can do to maximize safety. The other thing that we're noticing in our study is that the vast majority of impacts occur during practice. So, to answer the question, what's next? Well, let's number one, answer the question in a larger population. Let's do more longitudinal studies with more numbers of subjects, boys and girls. find out if there's a risk, and then do what we have to do to modify the game to make it as safe as possible. And it may be as simple as just modifying practices.
Well, let me share, before we go to Mr. Nowinski, I'll just share a little folk tale from my own life. Growing up in Brooklyn, New York, I'm a dedicated football fan, and I was dying to play for my high school team. And I had a friend of mine who had made the team. He was a lineman. And as entertainment for all of his friends, he used to kind of run at full speed and headbutt trees in the neighborhood. Now, my mother saw this because there was a tree right outside my house that he decided to headbutt. And she told me there is no way on earth that I am signing permission for you to play football if that's what happens. So I tried to tell no, he was just being exceptional. But I think for a lot of parents, it's a lot more binary. So, Mr. Nowinski, perhaps you can give your perspective based, I know you speak to people in a variety of roles that are engaged in football and who love it. And what should readers and parents take away from this work?
Well, first, I want to thank the research team for doing this study. I mean, it really does push the envelope on what we're learning about a very important population. I'm actually sitting at a football stadium right now for a high school because I'm running a very minor version of this sort of study on high school athletes for my dissertation in behavioral neuroscience. And this sort of work is informing that. But I think the big takeaway from this is, and we have believed this at the foundation even before the study came out, is maybe we shouldn't be hitting kids in the head so much. The big takeaway is that we've been talking about concussions for the last 10 years, but our CTE research is telling us that your risk of developing CTE is not related to how many concussions you had diagnosed. It's not related to how many concussions your family thinks you had diagnosed, or things that you thought you had. We've talked to people before they've passed away. There's no correlation between CT risk and concussions, but there is with exposure. And the fact that this study is looking at exposure and talking about exposure is a critical element towards us preventing brain damage going forward. So if we start talking about exposure, you're right that the key takeaway is we need to hit children in the head fewer times than football players. And the really sort of troubling thing about this is that children are the most vulnerable. I'm an advisor of the NFL Players Association, and 6 years ago in our first ever meeting, we said, you've got to cut the hitting out of practice. This is the one place you can have massive growth of reducing half your exposure. And they immediately collectively bargained for that. And now only one, as a way to test it, only 1 in 9 concussions happen in practice at the NFL level. Mm-hmm. At every other level of football, it's far more concussions in practice. And that's only because 8-year-olds can't unionize and high school players can't unionize. And the fact that football has not changed, it means that your child playing football right now is taking twice as many hits to the head as they really need to. All these unnecessary blows to the head that are leading to the brain changes that we're finding, or that the medical team found, and also what we're finding long-term once we take a look at the brain after someone's passed away. So this is just more evidence, and on a younger, the other thing this dispels is that the idea that youth football is like kids playing like a pillow fight. Because to your eyes, it does not look like they're hitting each other hard, right? Because they don't run very fast. But we forget, with all the biomechanical differences with their gigantic, nearly full-size heads and their tiny bodies and weak necks, it's not how much force they bring in, but it's how much they can slow down their head when it gets hit. And they can't. And so this is that proof that I think some people needed, that youth football is as dangerous, most likely, as high school or college, and every year is sort of the same. And that the more years you play, the worse off you could be. I mean, I hope some of these changes go away, but do we really believe that? Is it obviously not. Something's happening and sparking a long-term regenerative process, and this study may be capturing the beginning of that. Yeah. And so I think we have to pay dramatic respect to this. And I think when we talk about sports, we need to really vigorously delineate the difference between what's good, healthy sports for our kids and sports that hit our kids in the head 500 times. And There's nothing normal about hitting a child in the head 500 times. They don't do it to themselves. We put a helmet over their head so they stop crying and complaining. But now I think we're burying the problem deep in their brain. So this should hopefully will support more parents towards delaying the introduction of tackle football for their child until at least their brain is a little more developed, until they have a chance of having an athletic trainer on the sideline, which they never get before high school. We should look at the fact that at youth football, this is the only level of football where you might play 5 games in a weekend. You know, what Doc brought up about unregulated youth football. I mean, the NFL players are going crazy over playing Sunday and Thursday. Right. But they might have a Thursday game. And yet you can sign your kid up for a youth football program that has a jamboree where you play up to 5 games in a weekend. And there have been kids recorded dying from that because they had a concussion in the first game they didn't want to talk about, and they got one in the next game and died of second impact syndrome. So this sort of study provides that evidence that we need to continue to more strongly push that message to parents that there's nothing good that can happen with hitting your child in the head on purpose. And this is, 500 times in youth football is hitting your child in the head on purpose. And the brain can't tell whether it's football.
Your mother was a smart lady, is that correct?
My mother, so thank God my mom held me out of football till high school. I wanted to play when I was younger, and I ended up having a great 8-year career playing, and ended up playing as an all-Ivy defensive tackle at Harvard University. And I loved playing the game, but I am now at risk for long-term brain degeneration. Yeah. And thank God I didn't play longer, my risk would be higher.
Well, I want to thank you both. Dr. Whitlow, thank you for your study. I think this was a wonderful contribution. I think the discussion was very, very helpful for a variety of people who may be interested. Dr. Whitlow, please keep up your good work and keep sending us these fine articles. And Mr. Nowinski, if we have more papers to go through, we'd love to hear your comments on them. You added a great deal. So thank you both so much for participating.
Sure. Can I thank one group, and that is the Childress Institute for Pediatric Trauma, who funded our initial work. I think without their funding, we wouldn't have been able to get the preliminary data to move ahead and get the NIH funding that we have now.
So thank you both. Thanks for joining us.
Thank you, Ronnie.
Hi, this is Herb Kressel, and welcome to the December Radiology Podcast. Today I'm delighted to be joined by Dr. Pari Pantharipande, who is the director of the Massachusetts General Hospital Institute for Technology Assessment and associate professor of radiology at Harvard Medical School. Dr. Pantharipande and her colleagues from several different institutions, as we'll learn, have authored a very provocative study entitled Changes in Physician Decision-Making After Computed Tomography, a Prospective Multi-Center Study in Primary Care Settings. Welcome, Dr. Pantharipande.
Thank you for having me here.
Yes, if it's okay, I'll call you Pari, as we normally call each other. So, and you can certainly call me Herb. So, Pari, what's the background for the study? How did you actually decide to do this? Is like a very ambitious study. How did you decide to embark upon it?
So this question is one that is something that I think that most of us as radiologists really want to know all the time. It gets to the heart of when we practice radiology, when we interpret imaging studies, are we making a difference? What is it that we do that impacts care down the road? And I think that it's a very difficult question to answer in standard study designs. Certainly when you have something like CT or MR where all of a sudden we've been given this huge window into the inside of a human being, the idea to randomize patients to having that technology or not having that technology isn't really associated with equipoise. However, the technology has been disseminated, and some people feel to a wider degree than it maybe should be. We as physicians and as part of the medical community, we ought to be trying to determine whether we're doing the right thing by doing these studies, And one way to do that is to do a study like this where we get into really the thick of what's happening in clinical decision making on an individual patient level and see what difference imaging test makes.
Right. Now, I mentioned that there were quite a number of participating centers and co-authors. How did you go about identifying the centers and the primary care practices in each that would be participating?
Well, we wanted to have centers participating that were in different parts of the country. So we did that. We covered the coasts. There were 4 centers that ultimately participated, and they spanned the Northeast and the Mid-Atlantic, the Southern United States, and the West Coast. We wanted to have institutions participate that ideally were big, but that didn't have exact same makeup as of patients as one another. I think we were able to achieve that. And then we wanted institutions from a practical side that had the infrastructure and willingness to be able to do a study like this. You bring up in terms of how we found the practices within the institutions. This was a difficult study like that because unlike what I found, going in with open eyes, what I found was that PCP practices are quite unlike what radiology practices are like in these centers, which is understandable. They tend to be a little less in some of these centers centralized, mm-hmm. and some more than others, but there's a lot of heterogeneity in how that works. Of course, also, when you're working outside of your own field, you're going to be less familiar. You're going to be sort of one step away from the investigators that you work with. But that made it difficult to approach every PCP that's affiliated with these hospital systems. But we did our best to create a welcoming environment for PCPs to participate. And we adapted the ways in which we recruited people to whatever suited the sites best.
So reading the paper, your basic model was there was an online survey that a participating PCP would fill out before the exam was done. So you'd know who had an exam ordered. And then if they had agreed to participate in the study, they would be contacted and referred to fill out the pre-exam questionnaire. And then after the exam was done, there would be a post-exam questionnaire. And you would look at the differences in their assessment of the case pre and post as the primary study design. Is that sort of what was going on here?
Yeah, exactly. So we found again that different institutions had different ways in which they identified the cases done. But the basic premise was a PCP would agree to be part of the study. And once that PCP agreed to be part of the study, their ordering practices were tracked by research staff at each of the centers. And then when a study came in with an indication that was part of our study or potentially indication that was part of our study, our research staff reached out to them, and that's how the pre and the post CT studies surveys were completed.
Okay. Now you chose abdominal pain, weight loss, and hematuria as the sort of key indications that you looked at. How did you choose those 3? So
we chose those. I have to credit some of the PCPs at Mass General for helping with the selection of those. We asked one of the PCPs here, who's a leader in the field, Dr. Treadway. We asked her basically, what do you think are the big ticket items to study in a study like this? It's a unique opportunity, and she informally, I think, asked members of her group, and we came up with the indications like that.
So they were common, or they're the ones where the primary care physicians felt a priority they would get the biggest bang for the buck by ordering the CT?
I think, as I recall, we were going more for the common.
Okay.
Yeah.
Okay. And then, as I read it, maybe I missed this, but did this data you collected include what other lab or other data that the ordering physician had at the pre-CT survey time?
We did not.
Okay, so you didn't. So you don't know what other information they had that could have been driving their decision.
No, not at the time of the ordering. After the ordering, we tracked what kind of clinical or laboratory data there might have been available, but not at the time of ordering. The idea was that based on whatever they had at that time, we would see whether the CT would potentially make a difference.
So what did you find now that we know what you did?
So we found that for these 3 clinical indications, abdominal pain, hematuria, and weight loss, that the leading diagnoses after CT changed in about 50% or more cases when looking at each of those 3.
That's pretty amazing, I would say.
Yeah, we were surprised at the magnitude of the change.
Now, when I went to medical school, Pari, which I'm not asking you what you did at that time, but the sort of what we were taught was that 90% of the diagnoses could all be made with a good, thorough history and physical. And not commenting on how adequate the history and physicals were in these patients, but I never believed that anyway. And I think the 50% seems very, very impressive to me, but it certainly goes against conventional gray hair wisdom, I would say. Were you surprised?
Yeah. I think that I've heard a lot of people say that, and it's interesting. I've heard also a lot of people speak to something which you just alluded to, which is that does this somehow mark the decline of the physical examination in practice? And I've thought about that a lot. I've thought about that a lot, both with this study and another similar study that we did in the emergency department setting, which is also published in Radiology. We found these pronounced changes in leading diagnoses. I think
this could all be a reflection of the 12-minute appointment slot that most primary care doctors have to work with.
Yeah, so I think I think that's certainly a possibility. If you ask people who are on the front lines doing these exams, not us, doing the physical exams, I think that they in part agree with you. And I think in to varying degrees.
Yeah.
I think that, one thing that I will say that this study has made me realize, in combination with the emergency department study, is that there's another thing that we perceive. I started by talking about how people wonder whether CTs are, how useful are all these CTs. And there's this experience as a radiologist when you're reading CT scans that if you have, let's say, 1 and 2 CT scans as negative, or where you thought they weren't going to make a difference and in fact it didn't make a difference, you might sort of, from a behavioral perspective, you'll look at your experience and say, that's a lot of people for whom I'm not making a difference. And that's one way to look at it. But as a patient and as a referring physician, I think they often look at it actually more the other way, whereas 1 and 2 is a huge number.
I think, when we sort of hear this bulk data on unindicated studies, which are defined as things with negative results, I think it's a really distorted picture. I agree with you entirely. And I think that's a really, really key point. Now, the number of exams per PCP included in the study, there was great variability. Some it was just 1 and some it was like 30 or something. So that's a big, big spread, but the average was rather low. Is there an explanation for this? Was there some sort of cherry picking of what the PCPs would decide to fill out surveys on, or did they get tired, or what's going on here?
So I'm going to be honest here, and I don't think that looking at the data we can answer that question completely. I think that the PCP's participation in this study is something that I wish we would have had more people participate, and I wish we could have had a way to make sure that that didn't happen. But I'm sure that did, and that's one limitation of the study. I think that one thing that I learned about the difference in the way that PCPs practice, which I didn't fully realize, I think, at the time that I started the study, was that whereas in radiology, we're often working in redundancy. So in other words, I may work on a list that somebody else is working on. PCPs, almost all of them that I talk to, work in a longitudinal fashion.
Right.
And so their time constraints are much, much different. So I think that if I had to do it again, I would have, and knowing that, I probably would have figured out a different system to try to make sure that we could remove some of that bias. And the biggest thing that I probably would have done in retrospect, or if I had to do it again, were to compensate physicians more for their participation in the study. It was a real eye-opener to me.
And back-ended, maybe.
I'm sorry?
Back-ended, that the amount per case would go up the more you did.
Something like that. Yeah, we didn't remunerate people per case because I was concerned about any potential of incentivizing somebody. But I think that whatever way we remunerated people, I think that if I had to do it again, I would have substantially changed that to increase it.
It's a very, very different environment. Now, to deal with the potential confounders, that might be driving this very high rate of changes, you did numerous regressions from, I don't know, there were like 45 potential confounders or something that you listed there. And none of them proved to be significant. But again, the question is, since you didn't accrue the total number you wanted, what do you think? Is this a sample size problem, or are you concerned that the unidentified confounders still could be affecting the results?
I think that it's possible that there are some unidentified confounders. I think that because of this reason that you just said, we did not accrue the sample size that we wanted to. We tried our best in both our system design in terms of trying to put in certain processes in place to eliminate bias. For example, making sure that people didn't request to have a survey done on a particular patient of theirs, and we did our best to interpret the study results within the limitation that we didn't have the sample size that we wanted. And most of the results for the primary analyses were significant, but I think that the question you ask is a really important one, and I think that the honest answer is I think that's possible.
Yeah, well, I have to say, I think this is a wonderful study. It was a monumental undertaking, and I think you got a lot of fantastic information. So I just think clinical research is not easy, and you tackled a very, very difficult problem. So congratulations on the important information that you were able to extract. In your mind, what do you think are the key questions that remain? And do you think that the data that you have can lead to sort of more informed decision support models to help guide the CT utilization?
I think that, so those are great questions. I think that because we did not get the scope of the enrollment that we wanted, even though this is a fairly big study, it's a multi-center study, I think that to really understand this problem well, I would love to see a bigger a bigger, essentially better version of this study and more indications and maybe with more modalities.
Right.
So I think that before decision support tools get made, I think that's absolutely necessary. And the clinical data that could confound the results is also important to elicit. What else happens we don't have the detail in this study, as you alluded to initially, as to what else happens in the interim that could change the result equally. So we have some handle on that because we know that physicians, many physicians, or the vast majority of physicians per case, when they were asked whether their diagnosis of exclusion could be ruled out specifically related to the CT, that was an answer that was specifically attributable to the CT. But other things can happen to have somebody change their leading diagnosis. So there's limitations of this study, and I'd like to see a bigger version of this study done. What it does do in terms of clinical decision support, though, is something that we talked about earlier, which is that you can look at the 50% two ways. You can look at it as a number of people who have their decision-making changed, and you can also look at it as a number of people who don't. And so it gives us some scope. You can sit back and say, well, we're doing a lot as radiologists here, or you can say there's 1 in 2 people that we should not be doing a CT score for. So it gives us some scope of where such decision support tools, what kind of difference they could make if they're effective.
Good. Well, Pari, I want to thank you for a great paper and a wonderful discussion, and thanks so much for joining the podcast.
Thank you so much for having me. It's been a pleasure.
Great. Bye-bye.
Bye.
Hi, I'm Debbie Levine. I'm the Senior Deputy Editor of Radiology, and I'm here today with our Eiler Editorial Fellow.
Hello, I'm Meike van Rooij from Erasmus MC in Rotterdam, the Netherlands.
And we're here talking with an author of an article that's going to be in the December issue of Radiology. It's Dr. Emily Conant, who's a professor of radiology at the University of Pennsylvania, and we're going to be talking about her article entitled Implementation of Synthesized 2D Mammography in a Population-Based Digital Breast Tomosynthesis Screening Program. So welcome, Dr. Conant.
Hi, thank you very much.
So can you tell us a bit about what you did and what you found?
So at our institution, we've been using tomosynthesis in combination with digital mammography since September 2011. And we basically had about 4 years of experience and had seen improved outcomes in screening in terms of sensitivity and specificity, but we're concerned about the increased dose of that combination screening study. So we had a 4-month overlap period where we implemented the synthetic reconstruction of a 2D-like image and still did the 2D digital mammogram with the tomosynthesis as a learning period. And then in January 2015, we started screening only with the synthetic reconstructed 2D image with tomosynthesis. And basically the paper is discussing our early outcomes from the first 6 months of screening our clinic population.
Great. So just to summarize the findings, as I understand the major findings, you found that the cancer detection rate was similar for the 2 periods in time, one with just the digital mammography and tomosynthesis, and one with the synthesized 2D and tomosynthesis, but that you actually needed fewer biopsies when you were doing just the synthesized 2D images to obtain that same cancer detection rate. Do you have any other comments about what you found?
Well, we also found that our recall rate went down, and we were a little surprised by that because when we began using the synthetic 2D, the appearance of the 2D mammogram is somewhat different, and we thought that we might be overcalling or calling more women back when we dropped out the 2D dose mammogram, and we were surprised to see a further reduction in recall rate. So certainly with tomosynthesis implementation, our recall had gone down from just a 2D screen, but then it went down further with the inclusion of the synthetic view.
Do you have any explanations for that?
Well, I'm not entirely sure. I think that by this point we were in our fifth year of screening with tomosynthesis, and I think there's certainly a learning curve, perhaps longer than we thought, when implementing tomosynthesis and screening. And I think that we were perhaps more comfortable with just the whole study of tomosynthesis by that time. Also, our population, many of them were return screeners. So over time, that recall rate is going to go down with the advantage of prior tomosynthesis for comparison.
Okay, and you also found that there was a lower subjective breast density in the synthesized 2D group. Do you think this could also have contributed to the lower recall rates?
I don't think that contributed to the lower recall rate, actually. I think that that's, again, a very perceptual, qualitative assessment of the mammogram using the BI-RADS categories. And, we've shown in other studies that there's quite a lot of variability in that assessment from one radiologist to the next. I do think that varying breast types by thickness in particular and breast densities do look different on synthetic reconstructed images. And I think it's just a fact that they look a little different. It was statistically significant, though, which was of interest to us, and certainly something we'd like to pursue since density is such a hot topic in trying to personalize screening.
Right. Now, other studies, not your own, but other people, when they started looking at these synthesized mammograms, the reconstruction algorithms weren't as good for detecting calcifications. And of course, it's the microcalcifications that we're concerned about missing when we're screening for cancer. And it looks like from your population that that problem has been solved. But is there a possibility that you're still missing some lesions and missing calcifications? And do you think future algorithms for reconstructed mammograms will continue to improve over time?
So when I think about, tomosynthesis and how far we've come in the now 6 years that we've been doing it and since it got FDA approval and the early research, it's still very much an evolving platform. So yes, these reconstruction algorithms have certainly changed. I think they're better. I am sure they're going to get further refined over time, possibly driven by breast thickness and some kind of assessment of density. So I look forward to further algorithms. And again, the calcium issue is a very interesting one. We only had 6 months of data. So we look forward to certainly looking at our false negatives and our follow-up. Calcium and early DCIS detection is certainly a controversial topic in terms of overdiagnosis. What was it? If we were missing anything, were we missing anything? And those are certainly important areas that we'll have to further research. Don't have the answers yet to that, so lots still to be done.
One other question I had is that I found it a bit unusual that the synthetic synthesized 2D group would be more likely to be undergoing baseline screening. Why do you think that occurs?
I'm not sure about that because we had also looked at our baseline outcomes for yet another paper, and it's been pretty steady. But in this case, I think that more people are seeking out tomosynthesis to begin their screening and to continue their screening. And when we designate cases as baseline, I think we clearly defined it in the paper as either truly their first screen or despite all of our efforts, we could not get their prior mammograms. And so we had to process them as if they were a baseline first screen. So we didn't differentiate between those two scenarios. And I think that we've attracted more people in our region to screening at our site because of our use solely of, we use tomosynthesis on everyone.
Okay, and could there perhaps also be other demographic differences between the two groups of women that you compared?
So there were slight demographic changes, but things that I don't think are probably clinically significant. Certainly, if we go back to the baseline or no prior films, you'd expect that to increase a recall if you don't have prior films for comparison, and that was not the effect here. That did not seem to impact our overall reduction in recall. There were differences in thickness of the breast slightly, but only 3 millimeters, so probably not clinically significant. There were slight differences in race. We looked at risk, but none of them seemed to be of great difference over the two populations. Pretty stable.
Great. So you've obviously had a very successful implementation of both tomosynthesis and the synthesized 2D mammogram. Do you think there's enough evidence now available for other programs to implement this? And are there any legislative issues, for example, in the United States that might prevent people from making this change?
So, I think we're very enthusiastic about tomosynthesis providing a better screen and being the better mammogram, screening or diagnostic. I think in terms of implementing the synthetic aspect of this and not doing the 2D dose image, I think there's certainly a learning curve and an overlap time is recommended. Some sites have suggested to start with the synthetic imaging on a woman who's already had a 2D tomo combination study previously, and with synthetic reconstruction so that you can actually reflect back on synthetic and 2D dose and tomo before you just fly with synthetic alone. So there are different strategies. I do think that this is becoming prime time. Certainly, as I said before, further research on our potential false negatives. There are always false negatives. What were they? Is calcium an issue? All of those things have to be looked at more clearly, and ideally that would be certainly a prospective and multi-center trial.
Okay, could you share with us what exactly you're working on right now?
So I think everybody really wants more information on false negatives, more than just a single institution. We have published early data on our false negatives, but I think really looking at a larger population is very, very important. And when we look at false negatives, really understanding the biology of the cancers. How are they different? What are we detecting with tomosynthesis that really may be a more aggressive cancer possibly, or are we really not changing the biology of detection? That's certainly very important. Overdiagnosis is a hot topic. I consider it a team sport, the overdiagnosis. It's not only the detection, but it's the diagnosis by the pathologist and the treatment by the surgeon. But I think we need to look at that anytime a new modality is rolled out. So really drilling into the biology and the outcomes of the biology.
Well, that sounds wonderful, and I really appreciate all the work that your group has done looking at breast imaging for our patients and for the benefit of science. And so thank you for your time and chatting with us today.
Thank you all very much for the opportunity.